Hi, I'm Anna Fashandi. I'm one of the general surgery residents at the University of Virginia. Thank you so much for allowing me to present our work today. And today I'm going to be presenting on our study that shows bariatric surgery actually increases the risk of bone fracture. I have nothing to disclose. Obesity remains a growing health concern in America, with more than 2/3 of the population considered overweight and more than 1/3 considered obese. As we all know, obesity is associated with many comorbid conditions, including hypertension, diabetes, dyslipidemia, coronary disease, stroke, and sleep apnea. Bariatric surgery is increasingly being used to combat the obesity epidemic, with approximately 179,000 weight loss surgeries performed in the US in 2013. Most of these surgeries were sleeve gastrectomies or Roux-en-Y gastric bypasses, with far fewer gastric banding and biliopancreatic diversions. Bariatric surgery is currently approved to treat patients with a BMI over 40 or those with a BMI over 35 and obesity-related comorbid disease. Results of surgery have been shown to include both durable excess weight loss and sustained reduction of comorbid conditions. Although bariatric surgery has many positive effects on patient health, there is evidence of associated health risks, including an increased risk for bone disease. Studies have shown increased bone resorption markers and reduced bone mineral density after surgery. These detrimental effects on bone health are multifactorial and likely involve nutritional deficiencies, changes in mechanical loading, and alterations in various gastrointestinal and fat-associated hormones. Given these bone changes, several studies have been undertaken to assess the risk of bone fracture after bariatric surgery. The results of these studies are conflicting, however, and the true effect of bariatric surgery on skeletal fragility remains unknown. We therefore set out to determine the long-term incidence of bone fracture after bariatric surgery and to identify risk factors in bariatric population for fracture. Additionally, we aim to compare the risk of fracture in bariatric patients to that of propensity-matched morbidly obese control cohort who did not undergo surgery. All adults undergoing bariatric surgery between 1985 and 2015 at the University of Virginia were included in a database that provided patient demographic and comorbidity data, as well as operative details and postoperative complication data. The institutional clinical data repository, which captures all patient visits, was then used to identify patients who were evaluated and treated for a bone fracture. Next, the CDR was used to find a cohort of morbidly obese patients who did not undergo weight loss surgery. Patients were then matched on a one-to-one basis for the propensity to undergo bariatric surgery using propensity scores. So a total of 3,429 patients underwent bariatric surgery with a mean age of 43 years, and 81% of these patients were female. Nearly 80% of these patients had Roux-en-Y gastric bypass, 11% had gastric banding, 8% had sleeve gastrectomies, and less than 2% underwent either biliopancreatic diversion or vertical banded gastroplasty. So 220 patients total experienced a fracture, and that represented 6.4% of the surgical cohort. And the average time to fracture was about 7.6 years after surgery. On univariate analysis, patients with fractures were more likely to have undergone Roux-en-Y gastric bypass or to have a history of tobacco use, COPD, or CHF. Interestingly, 48 patients had one event with multiple fracture sites, and 50 had multiple different fracture events during the study period. Multivariate logistic regression identified Caucasian race and private insurance as patient factors that were protective against fractures. Conversely, tobacco use tripled the risk of fracture, and patients who underwent Roux-en-Y gastric bypass were over twice as likely to experience a fracture as those who underwent sleeve gastrectomy. In our final analysis, propensity matching on demographics and comorbidities, including BMI, yielded 3,880 patients with equal propensity to undergo bariatric surgery. This figure shows the balance of cohorts as assessed by the standardized mean difference within the cohorts prior to matching. The cohorts prior to matching are shown in orange, and then after the match, they're shown in blue. You can see that after matching, the groups were well balanced, with all standardized mean differences less than or equal to 10%. And it should be stated that the adequacy of the match is assessed by having a standardized mean difference of less than 20%. The groups were similar at baseline, except that the surgical group was more likely to carry a preoperative diagnosis of obstructive sleep apnea. Importantly, this analysis demonstrated that fracture risk was over 2 times more common in the surgical group when compared to the non-surgical group. The study strength comes from the fact that it's a very large surgical cohort with long-term follow-up. Additionally, using propensity score matching controls for many variables, including important comorbidities and BMI, which help eliminate the chance that increased fracture risk from bariatric surgery is related only to these patients' comorbidities or their morbid obesity itself. The study does have many limitations, including its retrospective design, which subjects the analysis to bias. Because the study only included patients from a single institution, it's difficult to say that these results are definitely generalizable to the national or international population. We also didn't have data on all patient characteristics that might affect bone health, including the patient's osteopenia or osteoporosis status. We didn't have access to their pre or post-op bone mineral density scans. We didn't have their history of prior falls, prior fractures, or their baseline activity level. And then we also didn't have data on whether or not they were taking medications that might affect bone health. And then finally, fractures were only recorded if the patients were seen and treated for that fracture at our university. So if they went out of network, they would not have been recorded, and therefore there would have been a reduced estimate of fracture risk. So in conclusion, we demonstrated that bariatric patients are twice as likely to experience a bone fracture when compared to propensity-matched controls. Moreover, the fracture risk is independently increased in tobacco users and those who undergo a malabsorptive procedure. So we should therefore counsel our bariatric surgery patients regarding fracture risk, especially if they're going to undergo a procedure that has a malabsorptive component, or if they're a tobacco user, we should help them with tobacco cessation in the preoperative setting. And then finally, we need to mitigate the effects of bariatric surgery on bone health by emphasizing strict adherence to guidelines for nutritional support and physical activity. Thank you so much, and I'm happy to take any questions.
Hi, I'm Shayna Eckhouse from Washington University in St. Louis. Did y'all look at vitamin D levels pre or post-operatively in your patients?
We didn't have vitamin D levels post-operatively to compare to, but we did have the ability to see whether they had vitamin D deficiency beforehand, and it was not a independent predictor of fracture.
Dr. Bowers. Yeah, are the patients any more at risk for assaults or sports-related injuries, or is the mechanism equivalent across both groups?
So unfortunately, we didn't have data on mechanism. That's another limitation that I didn't mention, because obviously, especially those patients who had multiple fractures at one time, that was probably a high-energy trauma, and unfortunately, we couldn't tease that out in our analysis.
Back microphone.
Hi, Mohammed Bawahab from Saudi Arabia, an upper GI and bariatric surgeon. My first question, I assume bone scan was done for all the patients pre-op, right?
I'm sorry?
Bone scan.
We didn't have bone scan data on all of them. We tried to pull that, and not enough came through in our system for it to be something we could use to compare.
Did we study the age as a factor in those patients?
I'm sorry?
Did we study the age of the patient as a factor?
The age?
Yeah.
We didn't, age, they were matched on age in order to control for that, but, and I think I said our average age was in the mid-40s.
Okay, thank you very much.
Front microphone.
What percentage of your patients had spontaneous fractures? And do you measure vitamin D pre-op? Because many of them, they have deficiencies already. So
we didn't have specific vitamin D levels. We had data on whether or not they were considered deficient, but we couldn't compare whether that got worse or better pre and post-operatively. And then, did you ask about what type of fractures they had?
Yes,
they ended up having. So most patients had fractures in the upper and lower extremities. That was about 70%. Hip fractures were only a little over 2%. And then there was a large category of other fractures that included things like spine and pelvis fractures. And so spine fractures would be considered a kind of osteoporotic risk site as well as the hip. So I can't really say whether bariatric surgery definitively makes osteoporotic fractures more likely or just fractures in general.
Thank you.
Sure.
Please identify yourselves to rear microphone.
Fahad Al-Abidi, Riyadh, Saudi Arabia. Well, do you think patients after bariatric surgery, because they become more active, more involved in sport, or their physical activity increase, does that have anything to do with making them more susceptible to injury?
I think it definitely could. I've read some studies trying to suss out whether or not fall risk changes after surgery, and that could be based on increased activity level afterwards compared to preoperatively, and also just changes in weight and muscle mass might make bariatric patients, at least for a time, at an increased risk for falls afterwards. And there haven't been any definitive studies on that, but it's certainly possible.
Thank you.